Hi, I'm Dr. Derek Lee, and it's my pleasure to introduce Dr. Aure Courvoisier, who is a pediatric spine surgeon and professor at the Grenoble University Hospital in Grenoble, France. Welcome, doctor.
Welcome. Thank you.
Did I get your name right?
Yes, Aurélien Courvoisier,
Okay.
which is quite difficult to spell it in English, to say it in English.
Okay, thank you very much. I'm always interested in asking surgeons their pathway or their career path in terms of becoming a surgeon and your interest in scoliosis. Can you talk a little bit about that, your history?
Yeah, so actually I'm a pediatric orthopedic surgeon. So at first I was not, well, in my early career, I didn't want to do scoliosis. I wanted to do orthopedic surgery and mostly pediatric orthopedic surgery. And I was very, very interested in, pelvis osteotomies and so on. And during my residency, I was very involved in spine surgery, especially in scoliosis management. And that was my first, touch with scoliosis. And then I did my, in France, if you want to do the professorship, you need to do a PhD and so on. So I did my PhD with Wafa Scali and Jean Dubousset. Jean Dubousset is a very famous French surgeon. And so he gave me the virus of scoliosis and particularly in 3D, he worked a lot on 3D management of scoliosis. I mean, he knows that very well. He gave me that. So I worked on my PhD was on scoliosis predictive factors. So I worked on that 3 years in a row. So after that, I couldn't do anything but scoliosis. So then when I started my practice, my actual practice, I mostly did scoliosis. And the more you do scoliosis, the more you do that. It's impossible now to do something else because, well, as you know, it's big surgeries, so it takes a long time. So once you do one or two in a day, but it's not possible to do anything else actually. So right now, I'm mostly doing spinal surgery, but I still do traumatology, and because we are a small team, so I need to do that. But my first the virus was Jean Dubousset, I think.
Well, I think he was a virus for many surgeons, yes?
Yes.
Okay. Well, what's your PhD and what did it teach you in terms of the 3 years and your data and your research in terms of predictability?
In fact, my PhD gave me maybe not a surgeon vision of scoliosis. As I told you, I was not born in scoliosis. I was I liked very much traumatology and lower limb surgery and so on. But this PhD, they gave me they taught me something that very important for me now. It's surgery is not the end point. What we want is to understand the etiology. How can we understand scoliosis to avoid any fusion at the end? And that was the. I mean, well, Jean Dubousset was is still like this. He has two. He is two trains before us. He's always thinking before us. It's very impressive. So he always told me not to think about surgery, but but more earlier in prevention and avoiding any well, understanding the scoliosis at the beginning. And that was the and it's still this mojo is still with me. I finally, the more I'm getting old, and the less I want to do fusion, and that's why I'm still fighting for early bracing, and that's why I end up doing VBTs and surgeries like this. And well, finally, this PhD was the trigger for my career in scoliosis. But from a biomechanical point of view and not from the surgery point of view. Finally, well, I'm putting screws because I need, well, some patients need that, but well, I am always thinking about doing things differently.
Very interesting, which I appreciate, because that was kind of one of my goals with these interviews, is to get a bit of a clearer understanding of what causes scoliosis, what makes it progress, right? And I've talked to many surgeons, and it seems that the predominant view right now, in terms of once the scoliosis starts, it's because the lengthening of the spine has become straight. There's a rotation because of different forces on the spine, and the scoliosis is almost a reaction to all that, to try and shorten the anterior column. Is that what your perspective as well?
Yes, actually, today, what I say to the patient is that scoliosis is a program, like in the computer. It's in the genes and in the chromosomes. It's something like we don't know yet the real etiology of scoliosis, but what says Jean Dubousset is that scoliosis is only the symptom of a bigger disease, something that we don't yet know. And actually, when we are treating patients, we are only treating the symptoms, not the real cause of scoliosis. And yes, so today the predominant, what is in my mind is if we, well, it's not yet we are not yet to know the real gene and the real cause of scoliosis, but if we are able to act very early in the evolution of scoliosis, then I think it's possible to change the evolution of most scoliosis. And it's sometimes a little bit frustrating in France, but maybe in other countries, that screening is not that good. And so we are, as surgeons, coming very late in the management of our patients. And I see also here in France, most surgeons, they see patients very late in the evolution. And now I have the opportunity, because I'm quite alone here in my area, to see most patients coming very early in the clinics. So I see patients with very small curves, and it's very easy to treat small curves. And when you see that, well, I know it's a little bit boring sometimes to see patients with very small curves and you don't put screws in all your patients, but actually it's much better for them to see us very early, so we can initiate bracing and other smaller treatments. I mean, minimal invasive treatments.
I think let's dive into that because I'm pretty interested in the bracing. Because if you could, the older the person gets with AIS, the bigger the curve, the more the options are limited. Correct?
Yes, of course.
What do you mean by very small curve? What would be your parameters for bracing at the very earliest?
Actually, today we are in France. Actually, if you want to be very well, actually in France the brace is reimbursed after 20 degrees, but if I see someone with 10, I won't brace. But if I see the same patient 6 months after and the patient has 15 or 16, then I will brace. It's not very conventional, but it's a lot easier to start a brace, and usually we start with a nighttime brace, so it's a lot easier for the patient. And well, I mean, if you have a 20 degrees curve or 15 degrees curve, it's a very flexible curve, so it's very, very easy to have a good correction in brace. So once you have a good correction in brace, it's very satisfying for the patient when they see the X-rays, the in brace X-rays. So they say, "Oh, cool, my spine is straight." So when I see them, then it's possible to tell them that, well, look, your spine is straight with the brace. So when you have the brace, you're protected. Your spine has a good protection. So it's a lot easier for them to be compliant with the brace. And usually I start with a nighttime brace around 20. And then sometimes when they are when it's a little bit more tricky because they are within the growth spurt, when the growth is very, very very high speed growth, I mean, then it's, yes, I do full-time bracing, but usually I do what I call out school bracing. Well, they put their brace every day, well, all day long, but not at school. So that means when they come back to school, well, they put the brace on the night, the weekend, and vacations. So it's speed 2 and speed 3. It's when it's full-time bracing, but it's I would say maybe 5 or 10% of my patients, not that much.
Question I have as well, just to follow up on the bracing, do you do nighttime bracing, and when you have to do daytime, do you also have a separate type of brace for that? So you're double bracing, 2 different types of braces?
Yes, sometimes, but actually I not that much. In my early career, I did 2 brace, one for the day and like an overcorrection for the night. But usually what we do is we see after we start the brace, we see the patients 1 month and 1.5 months after the brace initiation with the X-ray with the brace. And well, we were always frustrating, but because the day brace was always not as good at the nighttime one. So we put the nighttime one during the day. Well, because we don't do too much overcorrection, it's more like a big translation. Mm-hmm. And so that it's not very difficult to handle in during the day. So actually now I just have one. if I have a very, very small child with a very big curve, sometimes they have like thoracolumbar curve, very big ones. Usually I put an overcorrection brace during the night, but very asymmetric, so it's not possible to have it in the day. But now in my practice, I just put like Cheneau brace. It's mostly what I do. So these are asymmetrical brace, very French. It's what we do, and I think we do that quite properly. But no, I just, well, for most of my patients now, it's just one brace and the same brace during the day and during the night.
It's also pretty fascinating that, because I haven't heard it anywhere else in terms of not wearing a brace to school, but you wear it the rest of the day and the night. That must be very large compliance as a result of that.
Well, if you cut the day in three, you have, 8 hours you're at school, 8 hours you're sleeping, and 8 hours you're doing what you do. Well, it's if you don't put it at school, it's mostly 15 hours during the day. It's some, for most of the curve, it's enough. And when you start a brace at 10 years old and you need to have it until the 15 or 14 years old, it's long. It's very, very long. So usually I put the brace, I say, we start with the nighttime brace just to see how it goes. And well, you know, if you're going to your growth is not finished at all, but well, we'll see in 6 months how it goes. If we see it's very stable, just okay, we'll leave it like now during the night. But if it's progressing a little bit, we'll go, well, level 2, how it's cool brace. Finally, if you think about it, most of the girls, they don't want to put the brace at school. And if you tell them it's possible to do sports and you don't put the brace at school, well, it's pretty nice. Finally, the compliance with the brace is very high when you do that. If you started doing a full-time brace, well, it's cool for 3 months, 6 months, but sometimes it's they throw the brace and they say, oh, I don't want to put it anymore. So that's not good. So well, I usually, well, for some patients, when you see it's not gonna be okay, it's a full-time brace, but because it's like a 25-30 degrees curve before growth spurt. So well, you don't have any other option. But for most of the other patients, it's more, I always start with a nighttime brace.
You have some slides of bracing. Would you like to share that with us?
This is very academic presentation. So I will be quite fast on the first slides. So our philosophy is that the more you treat early, the more you have movement, because you spare, well, you put a brace only during the night, so it's possible to move during the day. As I told you at the beginning, finally the objective for all our treatment is avoid fusion, if it's possible. And this is what I do. Finally, the approach is early detection. So that's not my side, but that's, I mean, the most important thing for our patients, our children, is a screening. So we need to detect the curve and the rib hump, well, the screening of scoliosis is mandatory and needs to be systematic in our patients, in our children. And then the ideal solution would be to have predictive factors of evolution. But the problem is that they are not still very robust. So we still need to see a patient 6 months, each 6 months, or two times a year to see if the curve is progressing. But I feel that in five years now, we probably have good predictive factors. That means we will be able at the first X-ray to predict if the curve will be highly progressive or not. And if it is at risk of progression, then we won't need to wait for the second X-rays to put a brace, an external brace, because if you feel that you have a 80 or 90% chances or risk of evolution, that it's necessary to put a brace just when you see the patient for the first time. And then external brace, and if it's not working, then we shift to internal brace, means VBT. And if it's not working and you still have patients coming in the clinics with 70 degrees at 15 or 16 years old, and that's not possible to do anything but fusion. But I feel that if these steps are properly implemented in our health care in every country, it will be possible to avoid fusion for most of our children. So this is the approach, and well, as you may know, and you've done that, most surgeons surely show this kind of slides before. Natural evolution of scoliosis. These are 3 vertebrae, AP view, and you see that the growth speed on the convex side is higher than in the concave side. And this is a vicious cycle. That means that during the growth spurt, the more you have, the bigger you have, the bigger curve you have, and the more pressure you have in the concave side, and the less this side wants to grow. I always say my patient that AIS is a genetic program. In the program you have scoliosis, and you have this endpoint. That means it's already written here in the program where the scoliosis is programmed to go. Well, the endpoint is already written in the program. The severity of the scoliosis is written in the program, and that's very important. That because most patients that's why finally, physiotherapy or things like this do not work, because if you do physiotherapy for scoliosis that is programmed to end at 20 degrees, if you do physiotherapy or if you eat strawberries or whatever, it will end up at the same level. But it's very important to understand that the severity is in the program. So, and it's very important for us as surgeons to identify very, very early in the progression of the curve if it's a very highly progressive curve or not. And very early in the evolution, around 10 or 15 degrees Cobe angle, I'm pretty sure that it's within the 5 next years we will have the opportunity. We will have a closer idea of predictive factors that will give us will give us the identification of what is a progressive curve. And we work on that with Wafa Scali and Jean Dubousset. That was my PhD. So we identify predictive factors of curve progression. It's a transform. Well, it's different. Well, it's an identification of a curve pattern, a 3D curve pattern, which is possible to identify with the EOS system. Maybe you know that it's a system of radiography to that takes AP and lateral view at the same times, and so it's possible to have 3D reconstructions, but in a standing position. So now you can identify, like I'm showing here on the slide, like torsion index, rotation between the vertebrae, and so on. So if you combine all these parameters, it's possible to identify a severity index. And mostly what we identify, that's the transverse plane. I mean, the axial rotation. It's where it all happens at the beginning. And what we see is that, well, something happens here. We don't know yet why, but well, it's happening here in the rotation, in the axial rotation. And this is what we use now for the evaluation of our patient. It's the EOS system. The first thing is that this system is a very, very low dose system. So it's mandatory now for our patients to have that all the follow-up with this. There is no equivalent now on the planet. Actually, there's no equivalent. Maybe there will be someday, but actually it's cool because it's a French brand. So it's a French company now, and it's been developed in Paris and in Montreal in Canada. And well, what we learned from my PhD and from other works that we've done with Jean Dubousset and Wafa Scali is that, well, if you analyze very early the transverse plane, then you can identify, it's possible to identify progressive curves at an early stage, but yet it's not perfectly robust. So we need to have more patients, and we need to pursue these works. And but once you have predictive factors, then it's possible to select the good patients for bracing. And well, my vision is that the sooner is the better for brace treatment. I mean, today I'm pretty sure I overcorrect patients. I mean, probably I put brace on patients that maybe wouldn't need a brace because their scoliosis is not programmed to be very, very, very severe. But I prefer to start a brace, and then if the evolution shows that it was not that progressive, sometimes what we do is we just stop the brace during 6 months because we don't know what we do now. It's the spine is perfectly straight. I just say, well, we stop and we'll see 6 months after what is happening. And if the curve is progressing, then we put back the brace on.
Can I ask a quick question?
Yeah.
When you overcorrect, is there a certain percentage that you look to overcorrect to?
No, I mean, I overcorrect. That means I put a brace on patients that maybe wouldn't need any brace.
I understand.
That's my point. But well, you don't know at first because we don't have those predictive factors. So sometimes when I see a patient that was, I mean, 15 and it's going up to 20, 22 degrees, I feel I don't want to wait more and see what's happening. So if it's progressive and but still very low curve, I brace. But probably some patients in that category are not programmed to be very severe at the end. And but I prefer doing that and doing I mean a brace during the night, which is not very demanding, and usually it's okay. If 6 months after or 1 year after the curve is the spine is straight and there is still growth, then I stop the brace and I will we keep the follow up. And if 6 months after the curve is resuming, then we are going back with the brace on.
Okay, thank you for clarification.
And what is very important, and that was it's still a good message from Jean Dubousset, that if you want to have a good evolution with the brace, you need to have a good in-brace correction. So if you don't have x-rays with the brace, then you don't know if the brace is good or not. So it's very important to, if you put the treatment just one month after, you need to show your patients that the spine is better, the curve is smaller with the brace than without. And it's there are some papers about that, and it's very important that if you want to have a good progression with the brace, then it's necessary to have to show, well, to see if the x-rays with the brace. Well, the principle with the brace is usually what we say to the patient is that the brace only stabilize the evolution of the curve. That means it doesn't go back. It's not that easy to heal the scoliosis. So usually we only stabilize. So if you start with 20 degrees, the idea is to finish at the end of growth with 20 degrees. And why is that? Is because well, the vertebrae are asymmetric, and if as I show here, it's very schematic, but since the concave side is smaller than the convex side, when you put the brace on, you push on the spine, and the spine is flexible because of the disc. But once you stop the brace, well, if you still have this asymmetry, well, the curve is back. So what we aim to do with the brace is only rebalance the growth speed between the concave side and the convex side. So that's why for most of our patients, it's only stabilizing the spine, the curve, and not going backward. That means we are not healing the scoliosis. But sometimes it works. That means it's there is a real growth modulation, like what we do with VBT. We have the same evolution with the brace for very young patients. Well, when you have the perfect alignment of the planets, I mean, you have a good brace, you have a good patient, you have the good curve, and if everything is perfectly aligned, then I mean, 15-20% of our cases, then we have a good correction and a decreasing curve. I mean, the Cobb angle is decreasing after the brace. And this is happening, but that means there is a real growth modulation. So in pediatrics, pediatric orthopedic surgeon that knows, well, that when they do brace treatment, well, they are very familiar with that. So it's completely natural to go to VBT. Well, this is the kind of brace I use. It's a typical Cheneau brace. I do not do any plaster cast anymore. I feel it's very, very invasive, so we don't do that anymore. What I do is I work with what we call in France orthoprothesists, which are the brace manufacturers. And it's mostly an ambulatory process. That means I do the prescription. They go and see the guy that is doing the brace, and I see them back 1 month and 1.5 months after the brace initiation to see if the X-rays are okay or not. And mostly they are doing like this. They don't do any plaster mold, but it's all numeric now. It's with the it's all computerized conception. And what I told you before is that we need a radiological in brace evaluation, because if you don't have this, you don't know if your brace is working. And as I told you also, is we need to adapt ourselves to the patient. And what is important is not always do, if you always do just permanent brace, well, it won't work, because most of the patients, they will quit the brace because it's too difficult psychologically. So I have the nighttime brace, the at-school brace, and if there's a high progression curve, then I put the daytime and nighttime brace. I mean full-time brace. And I usually have two kind of brace. I use when I'm sure it's a lumbar curve, I use only a short brace, and for thoracic and doubles, I use a long one. So this is a short brace. Sometimes what I do is, you know, at the end, the problem is that they don't like, especially for the girls that are, well, when they are growing, at first it's okay, but once they are 13 or 14 years old, the problem is that here, they don't like having the brace here. Though that's not, they don't like it because of the breast. So if there is a double curve, and if I'm not too much worried about the thoracic curve, I switch from the long brace to the short one, just to protect the lumbar curve, because the lumbar curve is the one that will progress at the adult time. And then this is what's happening when it's working well. It's stabilizing the curve. And this is a long one. You see it's a little bit asymmetric, but it's okay. Well, this is what we've done. As I told you, this is the outcome of nighttime bracing with, this is a study we did, well, a long time ago now. So what you see is that most of our patients are stabilized. As I told you, it's 20% they are decreasing their curb angle at the end, but that's cool. But what you see also, that's some patients, they do progress despite the brace. And this is for that patient that we need to do VBT. Well, when it's working well, it's like this. So, well, this part of the presentation is more about what we are aiming to do in the future. So the problem with the brace is that it's still very depending of the guy who is doing the brace. So I'm working always with the same person. He's only doing bracing, well, brace for scoliosis. But it would be interesting to standardize the conception of brace, and that's why a lot of people are working on brace simulator. And the problem is that well, it's very easy to obtain the 3D the geometry of the spine with the EOS system. You know that we can have the spine, the pelvis. Now it's possible to have the ribs also. Well, it's still research, but it's possible to have the ribs and the spine. And as you know, it's possible to have the shape of the trunk. But what is difficult is to match the two geometries. So we work on that to create an avatar, a 3D avatar of the patient. And we did a study on this, and the idea was to try to put the brace only on the computer, just to do a simulation of the real brace on the avatar, and to see after a simulation, biomechanical simulation, to see if the spine is what's happening on the spine. And we compared the simulation to the real patient and to what the spine was on the real patient after the in-brace correction. These were the same person. And that was pretty cool because we in fact, we have more than 75% of good prediction. But it's still very demanding for the engineers. So it's not like a one click and you have the result. But it will happen. Someday we will have the good geometry. But what is missing now is not the geometry. The geometry is okay. We have plenty of good things to evaluate, to have a good evaluation of the geometry. What we don't have, we don't have the biomechanics of the patients. We don't have it's impossible now, and nobody has this, is how you evaluate the force you need to correct the spine, how the patient is flexible. Well, finally, if we have this, and we will have it, but not now. If we have this, then we will have very good simulators. We have brace simulators. We will have surgeries simulators. But for now, we only have geometry, and it's probably impossible to have a proper evaluation of well, a patient-specific evaluation of the patient's biomechanics. That we don't have that. So, and once we will have it, then we will have a very, very good simulators. But it's it's research, and it's still work in progress. And what we are also doing with the brace is trying to implement some movement in the brace. The idea for me is like what I've called the X-Men project. As you see, in the the X-Men, they have some like combination. I don't know the word. I forgot this. Well, the idea is something that you have. The ideal brace for me would be something that do the correction but allows the movement. Well, it's not that easy, actually. But first thing is to try to evaluate the movement and to try to understand the scoliosis not as a static spine, but as a mobile, in a mobile way. And so what we did is evaluation of the mobility of the spine. And so in my practice now, this evaluation is done for all patients that will have a brace. So we now have a very, we are just gathering data on patients each time I have a patient with the brace that will have a brace. Just for the first evaluation with the brace, they have the X-rays and they have the motion capture. And we did maybe now it's been 5 years ago. We did a study on motion analysis, and we compared LC patients, well, LC children's, and patients with small scoliosis. And what we saw is that they are not the same, even for very small scoliosis. And what you see here is very interesting to show is that when you the trunk is going like this, when you are not, when you don't have a scoliosis, well, the pelvis is very straight, it doesn't move. But when you have a scoliosis, you just shift a little bit your pelvis before you bend lateral. Well, that's an example of the small anomalies that you can see when you do a motion capture on patients with scoliosis. And so what we are aiming to do is to evaluate, to gather a lot of data on those patients, and then not only evaluate the scoliosis with the X-rays, but to have X-rays plus the motion capture, so that we will have a lot of data, and then maybe more data on the biomechanics of the patients. And what we did also is quite cool, is a connected t-shirt. So the idea is to evaluate the movement, but at home, to see our you have captors in the t-shirt, and you can gather data on how the patient is moving during his daily life. What you can do also is recording the movement during if you want to do rehabilitation or physiotherapy, you can record the movement and just compare it to an ideal movement. Well, that is still work in progress, but it's quite cool. It's working well. I mean, in the lab, it's working well. Well, the idea is that you have a live motion capture of how the spine is moving. Well, finally, the idea is to have early treatment of very, very small progressive curves, and well, and I feel in the future you will have more brace simulators once we know how to more properly evaluate the biomechanics of the patient. And someday maybe we'll have also, well, the future brace for me is something that is not rigid. or it can be, right. I mean, if you can imagine a brace that will stiffen when you're moving. Well, you will have some kind of robotics inside that will allow the movement and just help the spine being straight, whatever the movement you are doing. Well, that's the future.
Excellent. Thank you, sir, so much for your time. Really appreciate it.
Thank you very much for your invitation. That was cool.
Okay. Learned a lot, and have a great evening. We'll talk to you soon.
Thank you very much.